So my name is Michael Roy, and I'm the founder and executive director of Clearview Treatment Programs. So welcome to all of you. Really appreciate your taking the time out of your day to come here and be with us, and we appreciate your interest in this topic of DBT, and they'll be going into some of what DBT is Dialectical Behavior Therapy. I'm sure you all know that because you're here. And they'll be also talking about what DBT is utilized for, and kind of go into a pretty good amount of detail on sort of what constitutes DBT, what makes it a very effective treatment for a variety of disorders, a little bit of the research behind it, but really kind of like what makes up DBT and what it looks like. So you'll really learn a good amount about that. So I'm going to just give you I'm going to be quick. I'm going to give you a little overview of Clearview Treatment Programs. That's where you are tonight. And just kind of familiarize you with our programs. And if you need more information or like more information about that, there's some brochures. And I'll be here at the end and answer any questions that you might have. And of course, you'll be able to ask questions about why you're here tonight, which is to learn more about Dialectical Behavior Therapy. So again, I'm Michael Roy. I'm a LCSW, licensed clinical social worker. I'm the founder of and executive director of Clearview Treatment Programs. So we offer a full continuum of care here, from detox to 2 residential programs that I'll tell you a little bit about. We have a day treatment program in Westwood. We have an IOP, intensive outpatient program in Westwood, and we also have an individualized outpatient program in Westwood as well. Our residential programs are here in Venice. So we specialize in evidence-based practices, and these are a list of the evidence-based practices. We're very well known for dialectical behavior therapy. It's sort of a mainstay of all of our programs, but we also do CBT, acceptance and commitment therapy, seeking safety, which is a trauma, an evidence-based approach for trauma and substance use disorders, motivational interviewing, prolonged exposure therapy, which is a treatment for trauma, which we may actually do another talk on that, and DBT and prolonged exposure have been researched together for people that suffer from emotion dysregulation or borderline personality disorder that also have trauma. It's a very effective treatment for that. And we also utilize the matrix model at our dual diagnosis addiction and mental health program. So we have some collaborations. One of the newer things that we're doing, we're really proud of, is we've collaborated with the Yale School of Medicine. So we're doing an outcome study for our women's residential program on the effectiveness of that program. So we administer a variety of measures at admission, at every 3 weeks during their treatment, at discharge, and then a 3-month and a 9-month follow-up. So we're really looking forward to getting the results of that over time. It just started about 9 months ago, I think. So after we get a little further out, we'll have some data to report on. And then we do a lot of other collaborations that you see up there. Again, I want to kind of just move through this sort of quickly so we can get to the presentation. So we have our Center for Psychiatric Disorders and Addictions. That's our dual diagnosis center. It's a residential program. It's just on the other side of Lincoln Boulevard. It's a co-ed, 15-bed residential program. And we do a lot of DBT there. We also treat, in addition to substance use disorders like alcoholism and drug addiction, we treat a lot of mood disorders, bipolar disorder, depression, anxiety disorders, PTSD, and then we also see quite a bit of personality disorders, including borderline personality disorder there, that are co-occurring with the addictive disorder. It's a small program, a very intimate environment, and it's all group and individual therapy, as well as sort of ancillary types of activities like yoga and a lot of mindfulness, and we take them on outings to the gym, and also to a lot of 12-step and other types of self-help types of groups like Smart Recovery and Refuge Recovery, things like that. So our other residential program, it's here. It's actually, the program operates in this building, and that's our Women's Center for Borderline Personality Disorder and Emotional emotion dysregulation. So a lot of the women that come here do have a diagnosis of borderline personality disorder, BPD for short. And also, but not all of them, some of them might have traits, or they might just really be struggling with emotion dysregulation or other things like self-harm or suicidality, suicidal thoughts. And then, they have other things like sometimes, they'll have depression, of course, and other disorders that commonly occur with BPD, or they might be coming here, for that, and DBT is a good treatment for them. So same thing, it's a very intensive group and individual therapy program, and they sort of like the women that come here, they really like live and breathe DBT, literally, and you'll hear a little bit about that, but like 24/7, they get a lot of coaching in the milieu, and they get after-hours phone coaching from their therapist, and they're in several DBT groups per week, along with individual DBT therapy. We have DBT consultation teams that you'll learn more about in the presentation at all of our programs. It's a really sort of dyed-in-the-wool, by-the-book DBT program based on Marsha Linehan's model of DBT. And then a lot of other therapies that you see kind of towards the bottom. We also have, we have an outpatient center in Westwood. We have a full day program. It's 5 days a week, about 6-7 hours a day. A lot of the same types of therapies that I just mentioned, so I won't go into detail about that, but very similar to what I already described, but on an outpatient day basis. So people can live at home, or they can live in a structured living environment that we can help them find. Then we also have the next level down is our IOP program, which is 3 to 5 days per week, 3 hours a day. And we actually started an evening IOP program in Westwood just this past August. And that's a great option for people that are in school and work. We actually are getting a lot of UCLA students in that program. And then we have a more individualized outpatient program where the clients coming in can sort of like select from a menu of a lot of different groups and services that we offer, and sort of put together more like a customized program. And then we have a standard outpatient DBT program, which is how DBT was originally developed, which is one skills training week per week, one individual session, and then phone coaching. And that's the lowest level of outpatient care. And then all programs, of course, include individual therapy or case management. If someone has their own therapist, they can potentially stay with that therapist and get the rest of their treatment with us. And then all the programs have a psychiatrist involved. There's 3 different psychiatrists that work with the different Clearview programs. And then we have a dietitian available as needed if someone has, we're not an eating disorder program for people with like more severe eating disorders, but when people are struggling with eating issues at a little bit lower level, then we do treat those as well. So we have a dietitian that will work with those clients. Then we have 3 different family programs. We have a 5-week family skills class that we offer at our women's center. I guess I should go in order. So we have a family support group. It's a free service to the community. It's Tuesday evenings at 6 o'clock, open to any family member that just wants to get support and learn more about what their loved one is struggling with. But it's really more focused on supporting the family member, or it could be a friend of someone that's struggling. They don't have to have anybody in Clearview. It's just open to anybody. And we have a 5-week family education skills class here at our women's residential program, and that's done over the phone because we get a lot of clients from around the country, sometimes even out of the country, and it's done over the phone. And they learn the skills that the clients are learning, so they can sort of start to speak a common language and learn how to really communicate more effectively. We also have a 2-day intensive family program where it's all the clients and families together at our dual diagnosis program across the way here, across Lincoln. And then at our outpatient, we have a 2-day intensive family weekend where families come, the clients aren't there, where they're again learning sort of the same skills that the clients are learning. And then there's individual family therapy throughout all the programs. So we do a lot of different service workshops and education for the community, for clinicians, for the professional community, and we've just started doing these that you're here for, which we call our community education series, which we're doing like one every other month, and we'll be sending something out about what the topic of the next one will be. What's that? Oh, I'm sorry. And we do sponsorships at national conferences. We do in-services at hospitals and institutions. We really try to get out there and help to educate people on what we do, but also on sort of the types of treatments that we offer and a variety of things. Lastly, we do take insurance. We work with a lot of different PPO plans. That's out-of-network insurance. We're also in network with Anthem Blue Cross at our dual diagnosis residential and our PHP and our IOP program in Westwood, and then we're out of network at our women's program. We're in the process of probably going in network with a couple other of the big insurers that probably within the next few months we'll be announcing that. And we do, the whole deal. We verify the benefits, we do the authorizations along the way, the utilization reviews, and then we build insurance, and so we really try to help to offset the cost of the treatment. And there's our information. Info at Clearview Treatment goes right to me, so if you would like to reach me, that's how you can do that, or Michael at Clearview Treatment is the same email, and there's our phone number as well. So I'm going to go ahead and turn it over to Molly and Kate. And Molly and Kate are therapists here at our women's program, and both are intensively trained in DBT and are really super experts at treating women with emotion dysregulation, with borderline personality disorder, and at providing really expert DBT. So here you are.
All right, so while Michael's switching that over for me, how many of you are familiar with DBT? Like pretty familiar? So, most of you. How many of you, this is pretty new? We get info. All right, okay.
Those are the clinical terms.
Yeah, pretty new. All right, great. So hopefully there will be a lot of good information for you guys. We're not going to go super in depth with it. We are trying to find that balance that we're going to talk about even more, which is the essence of DBT, and really giving you guys some of the basics as well as going into more depth with some of it and seeing the application of DBT. So, DBT is one of the treatments that's been shown effective in treating mood disorders, personality disorders, and we'll go into more detail there in a minute. And it's really kind of the gold standard for treating borderline personality disorder, which I don't think I see any familiar faces from last time. Was anybody here last time? No. Okay. Michael, yep, you were. So we are going to do a little bit of a review with borderline personality disorder because that is so important with DBT. That's why DBT was created in the first place. And we're going to use a lot of our role playing and examples that we do will be in regards to somebody who's struggling with BPD, borderline personality disorder. So first we want to start at the beginning. Why was DBT created? And Marsha Linehan was, not too long ago actually, came out and disclosed that she struggled with BPD and with chronic suicidality and self-harm behaviors, and found in her work that there just wasn't a treatment approach that was appropriate and effective in addressing these really high-risk populations. And so what she found was that acceptance-based approaches that didn't push for change really weren't helpful for this population. Because if you do have familiarity with BPD, which again we'll go into a little bit more detail in a minute, people who struggle with that, it's not a great label for someone who has difficulty regulating emotions. It's a disorder of the emotion regulation system. And due to that, life just feels intolerable. It's hell. It's hell for the people who struggle with that, not knowing how to regulate that. So if you're somebody who is constantly in this state of distress, feeling like one of the only options that you have is suicide, which is a horrible quality of life if that's what it feels like the only option is, then having an approach that says let's accept that only and not have there be change involved wasn't working. So it also wasn't appropriate due to the high risk of people struggling with that. And then Marshall also found that an approach that was behavioral, like CBT, that pushed for change only, was really invalidating. That the person who was struggling wasn't getting to have that space to be in acceptance of their experience and to feel really heard and understood in their experience, that they were just kind of getting moved out of that space and toward change. And that also felt unbearable, because what we also know is that this population of people also struggle with change, but that's really hard as well. And it's hard for most people. Change is not easy. And so having that as the only approach also wasn't found effective. So what Marcia did was she combined them, and DBT was born out of that, that we are really trying to balance and practice both acceptance of where the individual is at in the moment, as well as pushing for change, which we'll talk a little bit more about that in a moment. And that moment is now. Forgot how these were lined up. So dialectics, again, that's the essence of DBT. That's why it's called Dialectical Behavior Therapy. This is where we're balancing two things that are opposing, which seems counterintuitive, and yet that is what makes all of this possible. What really makes change possible is being able to first be in a place of acceptance and then also move toward change. So some of the dialectics that we are striving to find synthesis in, which means that we're not trying, if we're finding we're really polarized in one area, actually there's like a, yeah. If we're like over on this end of the spectrum, it's not that we're trying to jump over here, because we know that being on one end of the spectrum and the other isn't always effective. So with skill enhancement, for example, this is where the what happens here is that you're just adding tools to your tool belt, essentially. You're gaining skills. It's skill acquisition. And what can happen if we stay over on that side only is that our view becomes really rigid, that we start to think, oh, well, kind of like the shoulds come up, where we think, well, I should have applied a skill there. I wasn't feeling good. I should have known that I had this tool in my tool belt, essentially, which isn't always the most effective thing. So then over here on this side, this is self-acceptance, where we might find if we hang out on this end of the spectrum that we're just kind of sitting in complacency, that, all right, this is how it is. I'm just going to accept this, and even if it's something that maybe I can do something about, I'm not going to. That's not effective either. So with dialectics, we're trying to find a synthesis of the two and walking that middle path and finding that balance. So the second dialectic that we're balancing here is problem solving versus problem acceptance. So problem solving is where we are trying to solve the problem. And this isn't always effective. That's actually one of the things that we cover in DBT group, is when to problem solve, how to know when it's more effective to problem solve or more effective to try to accept that this is a problem that exists and it's maybe not a problem to solve. That you can imagine that if we're constantly trying to solve problems, that's not always effective, and it's actually sometimes considered willful. That we're willful to reality, that there is this problem that exists. The third one is affect regulation versus affect tolerance. So again, on this side, we're looking at trying to change how we are doing things. So using the DBT skills, we'll talk a little bit about the modules that address this, emotion regulation, which is change-based. So using the skills to regulate your affect versus using skills to be able to tolerate. So sometimes it's not always an emotion that we need to change or do something with. It's just knowing that this is an experience I'm having, I'm going to work to tolerate it. And then the last one is self-efficacy versus help-seeking. This is a really important dialectic to balance as well, that we don't always want to. Sometimes we fall in the trap or have the myth that we've got to do it ourselves. A lot of us, I know I've held that myth myself before, that I've got to do it myself, or sometimes the myth is that I'm weak if I can't do this on my own. I have to be able to do this myself. And what happens is that actually chips away at our resiliency and our ability to do things effectively. So we want to find the balance between knowing when we can use skills and how to use skills and to do it ourselves versus when to seek for help, because we also don't always want to be going toward help every time we need it. If we can actually do something to regulate it ourselves or have that self-management piece. And I don't know if Michael mentioned this, but we definitely want to hear questions. Please save them for the end, though, because we might cover the question while we are talking. So one thing that DBT isn't, this is something that it can be tough to talk about. I know that sometimes when I have this conversation with parents of clients who really struggle with chronic suicidality, it's tough to talk about this. But DBT is not a suicide prevention treatment approach, and that is a hard reality. It is an approach that is aimed at increasing the quality of life, because individuals who struggle with pervasive emotion dysregulation and high-risk behaviors, they don't have a life worth living. So the goal is to create and get that life worth living where suicide is no longer on the table, that it's no longer the only option, that we are helping clients to develop other options. So why is DBT considered the gold standard for treatment for BPD? It's more cost effective than TAW or TAU as treatment as usual. So it's more cost effective than treatment as usual. Which part of that is when a client is engaging in DBT and they're really committed to the program and acquiring skills and applying skills, what happens is that you see, I'm going to jump down a few, fewer and less severe self-harm behaviors, which means that there's going to be fewer emergency medical visits, fewer inpatient stays, clients aren't going to be hospitalized as much. So that in itself is going to be more cost effective. We also see better treatment retention. So clients that stay in and really again are committed to DBT are retaining the skills as well as staying in treatment. So two things there. And anger, that's a cornerstone of BPD. That's a really big piece of BPD, and Molly will talk a little bit more about that in a minute. When we're using emotion regulation skills, distress tolerance skills, mindfulness, interpersonal effectiveness, all the modules of DBT, you're going to see that there's a reduction in anger, which is a very big piece of pervasive emotion dysregulation. You also see better social and global adjustment, less drug abuse, and equal or superior reductions in depression, hopelessness, and suicidal ideation. So, is that you?
That's me.
I was just gonna keep going. Just keep going. How'd you do that tricky little, this is the skull, and then the top
laser
one?
pointer?
Yeah, the top.
Oh. So, that's exciting. So what does DBT treat? So Kate has already talked a little bit about how DBT has been formulated essentially to treat borderline personality disorder. That's essentially what it started out doing. Marcia's first study that she conducted to pretty much determine the efficacy of DBT was for women with BPD. That was the first study that was conducted that was shown to be effective. DBT was shown to be effective. So we know that it's effective for BPD. It's also very effective for binge eating disorder, bulimia disorder, substance use disorders, PTSD, depressive disorders, and bipolar. So that's really exciting. It's also starting to be implemented into schools. So young kids are starting to learn these skills, which is so exciting. They're learning how to be mindful, they're learning how to breathe deeply and be in the moment, and that can resolve so much of these behavioral issues early on. Pretty much for anyone. Kate and I, we use the skills all the time. So the DBT skills are not only helpful for these, they can be helpful for a lot of different people in general. What it hasn't been shown to be helpful and effective for have been a few different disorders. So anorexia, DBT hasn't been shown yet in studies to be helpful. Thought disorders like paranoia, psychosis, schizophrenia, those kinds of disorders hasn't been shown to be helpful. And what's the third one? And anxiety disorders, some anxiety disorders that hasn't really been shown to be effective. So,
And when, just to jump in with the psychosis or thought disorders, if it's managed with medication, it's effective. But if it's severe and it's not being managed with medication, then DBT is not going to be as effective.
exactly. Why isn't this going? There we go. So before we go into DBT, I just wanted to talk a little bit about borderline personality disorder briefly and really explain what that is like to get a better understanding, because BPD can look so different depending on who you are and what criteria you meet within the diagnosis. So think of BPD as a problem within the system that regulates your emotions. So behaviors regulate emotions. You know that if you have an emotion, you'll also want to engage in a behavior. So for example, let's say a bear crawls into this room right now. What do you think would come up for me? Or for you? What emotion do you think you might feel? Fear! What does fear make you want to do? What would you want to do with that fear? Run or scream, or if it's in that door, I don't know where I would go. I'd probably climb up on the step. So emotions elicit action urges, which make you want to do behaviors, right? Think of BPD as just this heightened experience of having an emotion, a little bit like getting a headache versus getting a migraine. So how many of you get headaches from time to time, where you wake up, you don't feel that great, maybe you're a little slower throughout the day, but you can function, you can take it with you, you get to work, and your mood is a little bit off, you don't feel amazing, and you can still kind of talk and get through the day. That's just a headache. That's maybe having an uncomfortable emotion. Who gets migraines? Has anyone ever gotten a migraine before? Yeah, I get migraines. It's not. Imagine BPD and the severe emotion dysregulation as a migraine, where all you can really focus on is that unyielding pain. And you can't think about anything else other than, how do I get this pain to go away? I can't go to work. I can't talk to anyone else other than about how I'm feeling right now. So if you think of emotion dysregulation in that way, and just the change in intensity from a headache to a migraine, that's how people with BPD experience emotions. They're just so much stronger, and they feel so much worse. And they do these behaviors much of the time to get rid of, or to numb, or to move away from the pain that they're in emotionally. So if we think about it through that lens, DBT works at teaching effective skills to either accept the pain and live with that and create a life worth living with that, or do something to move away from the pain that isn't destructive, like self-harm or substance use or whatever it is. We'll fill in the blank. So real quick, before we go through, I just wanted to talk a little bit about the criteria for DBT. You have to meet 5 out of the 9 to get the formal diagnosis. And if you think about it, there's 9 here. We'll go through them real quick. But if you have to only meet 5 out of the 9, one person might meet 5, 1 through 5, and then another person might have 5 through 9 and have a completely different presentation. And so that's why BPD is so heterogeneous. You can look very different from another person with BPD because you just have different parts of the 9 criteria. You just look very different. So the first one, number 1, you have a pattern of intense and unstable interpersonal relationships. So maybe one minute you idolize this friend of yours and they're just your best friend, and then all of a sudden they do something to hurt your feelings, and then they're unjust. They're not your favorite person, and they're just, they're not in your life anymore. So someone with BPD might have that very black and white thinking around relationships. They can also just have a lot of different arguments where kind of the anger might come in. So it's very intense, unstable, up and down, never really knowing what you're going to get. Number 2, frantic efforts to avoid real or imagined abandonment. So this is the fear of abandonment that we talk about all the time with BPD. So it's that hypersensitivity to perceiving rejection and then doing things to mitigate that, whether it's attaching to that person or pushing them away. Number 3, identity disturbance or problems with sense of self. So not really knowing who you are, not having a strong identity, not having things that you can really attach to and ground in within your own identity. Feeling like you don't really know who you are, who you're supposed to be. Number 4, impulsivity. This one is very frequent when we talk about people with BPD. This I think of as substance use. You can engage in any behavior that, like I was talking about before, tries to regulate how you're feeling. So drinking, using drugs, eating disorders can come into play, running away, compulsive spending, that kind of thing, anything really impulsive. Number 5, so this is the recurrent suicidal behavior, gesture, threats, and self-harm. So you have to have one of these kinds of behaviors, or maybe you could have 5 of the other ones. And this is the one where you got really you don't feel like you have a life worth living, and you go to a behavior to escape that. It's the solution to the problem that you have at hand. Affective instability means you have a really labile mood, so your mood goes up and down all the time. This is that walking on eggshells kind of phenomenon where you don't know if you're going to say the wrong thing and then their mood's going to shift like that. And that can be multiple times throughout the day. It can be, you just feel like you're on a roller coaster if you have this. Number 7, chronic feelings of emptiness. So yeah, this is kind of similar to lack of sense of self, just feeling empty inside, feeling that not really in touch with your environment around you, not feeling a strong connection to other people. And number 8, inappropriate, intense, or uncontrollable anger. So this can look like externalized anger, like yelling, lashing out, throwing things. It could also look internal, so you can be really, really withdrawn, negative self-talk around your own personal judgments. It can be internalized or externalized. And number 9 is the last one, so transient stress-related paranoid ideation or severe dissociative symptoms. So dissociation, does anyone know what dissociation is? It's like you're checking out a little bit, you lose sense of time and place. And that can happen when you're in a really stressful situation. It's your body's mechanism to protect itself from the stress that you're under. So those are the criteria, and you can see how if you have just 5 of these, and someone else might have 5 and only really overlapping with 1, it can look very different depending on who you are. If we were to reorganize the criteria in the dysregulation lens, which we do a lot of the time in DBT, this is the same criteria, just split up into 5 different areas of dysregulation. So I'll do this quickly for the sake of time. The emotion dysregulation, that's where we consider mood swings, intense anger, the rage, that's the emotion dysregulation piece. Interpersonal dysregulation, so that's where the interpersonal chaos comes in, the fear of being abandoned, that hypersensitivity to perceiving rejection. The self-dysregulation encompasses feeling empty inside, not knowing or having a good sense of your own identity or self. The behavioral dysregulation is the self-injury, the suicidality, the impulsive behaviors. And then the cognitive dysregulation includes these 3, the dissociation, paranoia, obsessions, and it can also include rumination, so when you get stuck in your head and you just keep going and going and you really can't get out of that thought process. So that's also included in here. This is what it feels like sometimes to have all of that. You feel miserable, you feel like you're in hell, and this is where the suicidality can come up because a lot of the time you don't really feel like you have another option to get out of the misery that you're in. So we're going to introduce our pseudo client, Jane Doe, and we're going to use her throughout the rest of our presentation within some role plays and examples to kind of bring this more to life and illuminate what it can really look like. Almost.
I'm so excited.
I know. So, so how does DBT treat this misery that these clients can come in with? First thing you want to do is define your values. What do you value in life? What gives this life worth living meaning for you? What makes it meaningful? Why are you buying into this whole thing called life, right? Defining your values and setting long-term goals to look ahead and kind of attach to when you feel like you're just getting thrown around by your mood and your emotions. So that's really important. Building relationships and building mastery. So strengthening your interpersonal relationships with your family, your loved ones, groups, peers, all of that. And then building mastery can look like getting more accomplishment within even learning skills. The DBT skills can be a great example of that. It can also mean just finding things in your life that you feel like are difficult and you can do them. So it's getting that sense of, oh, I have some control over what I'm doing. So that's first. And there's this, where is it? Oh, no. There's this house right here that we use a lot of the time when clients first start DBT, especially at the Women's Center, because the Women's Center is a residential level of care and they come in with the really high acuity where they are self-harming, they've had multiple attempts on their life, they are out of control and they are just miserable and they don't know what to do. The way we introduce DBT in the bigger picture is with this house that our consultant Charlie Swenson came up with to describe what the bigger picture of the process is like to go through DBT from the very beginning if you're coming in at that misery state. So imagine that this house has a basement, and you see right here, what are these? Fire, flames. You come in and you're in hell. You feel like you are in hell. There's no out, and it's miserable. So this is a lot of the time where clients come in, and remember that these clients are self-harming, they are just out of control a lot of the time. They feel out of control. The only way out of hell is through this ladder that goes up to the first floor. This ladder is made of metal. So what happens if a metal ladder is sitting in flames? It's really hot. And what do you want to do if you're climbing up this hot ladder? You want to jump off. So we say, okay, yeah, you might want to give up right now. It's uncomfortable. We're asking you not to self-harm. We're asking you to buy into life and to not do the behaviors that have been working for you more or less, that you've been trying to do for a long time. They're just not really working long-term for you. So they might want to jump off the ladder. You might get temporary relief from that pain, except you wind up back in hell. So it's this really horrible pattern that you feel like, okay, I'm going to try the skills, but they're not working. You want to jump off, you're back in hell. What we really want to point out is that if you stay on this ladder for long enough, meaning if you try these skills that are new and create new neural pathways in your brain, it gets a little easier. Because then you wind up on this first floor in stage 2 of DBT, where your behaviors are much more in control. You have the skills solidified enough to feel these really high urges that are born out of the high emotions that you're having, high intensity emotions, and still be in control, feel in control. So stage 2, and I won't go through the whole house because this is really where the meat of DBT lies, especially at this level of care. At stage 2, that's where you start to experience your emotions and really feel them and learn that you can just feel your emotion and not have to do anything about the emotion. You are mindful of it. If you have a history of trauma and you're experiencing PTSD, this is the stage at which you learn to regulate those behaviors and process that trauma. If you can imagine processing trauma, that creates a lot of really strong emotions. So that's why we don't recommend processing trauma in the first stage of DBT, because you need the skills to be able to feel those emotions without engaging in behaviors that might put your life at risk. So does that make sense, the house of DBT? So that's what we tell the clients when they first come in. A lot of the time, especially if they're struggling with motivation to get through that really hot ladder, they need to know that it gets better and you have to stay on in order to get there. And now Kate will tell you about modes.
Now it's actually.
Now it's your
Okay. So now we're going to talk about how DBT applies to our lovely, where is she at? Jane Doe. So Jane Doe is struggling with pervasive emotion dysregulation, and she's struggling with these behaviors that Molly was talking about, with intense anger and self-harm behaviors, and with that anger lashing out at people, and which impacts her interpersonal relationships. So Jane has come into treatment, and when we're talking about comprehensive DBT, there are different modes of treatment that are present. The first one is individual therapy, and this is where the client will have session with their therapist, and during those sessions, you'll really get into the interventions like behavioral chain analyses, commitment strategizing, on just getting the buy-in to change these behaviors and do this really, really, really difficult work that's going to help get to that life worth living. This is where there's really that motivation for the client is developed. Another mode is skills coaching groups. So Michael went over that we have several evidence-based groups here. At Clearview, one of them is the DBT group, where clients are going to learn the skills that are part of DBT. And they're going to get to do role plays and examples together. They're going to have homework that's assigned to help them reinforce the skills as they learn them, come back and get feedback on that. And then also, they bring that into the individual therapy sessions as well. Another mode of comprehensive DBT is family sessions and case management. During the talk back in July, we talked about the myths that go along with BPD. One of the myths is that you don't want to have family involved. How far from the truth can you get? We want family to be involved. It's so important to have family involved. So part of comprehensive DBT is having that involvement in some way, shape, or form. It's different, for everybody. Some people's family constellations look different, but family work is a big part of this. Phone coaching is also one of the modes of comprehensive DBT, and this is where the client really gets to call the therapist when they're outside of session or program and really get that feedback for generalizing skills. That's part of what we want to do with DBT. Is there's kind of 3 steps. There's skill acquisition, where you come in and you learn the skills. Skill application, which is where you now know the skills and you're learning when and how to apply it. And then skill generalization. That's where you take the skills that you've learned in treatment and you figure out and get your footing on how to apply it to your life in the ways that are meaningful. So part of what phone coaching is great for is, as you're out there in the world trying to get your footing and figure out how these skills apply to your real life, you're going to need some feedback, need some support in that. So phone coaching is part of getting that feedback and that support through that process. And then the last mode of comprehensive DBT is consultation team. What that means is that the providers who provide comprehensive DBT also have consultation meetings where they get together with the other providers and talk about their cases. And some really important aspects about this is that's so important, is that you're getting different perspectives. It's not that there's any one or absolute truth. This is what's dialectical about it, is that I may have a very firm belief of how to approach and use DBT interventions with a client, and Molly may say, you know what, I wonder if there's another way to think about this, and did you consider this? And that really helps to give the clients the most effective treatment, because we're getting lots of different perspectives, we're consulting. And the other really important aspect of consultation team is that we're using DBT on ourselves. We're not just saying, this is what the clients need to do. We're also keeping ourselves accountable and using DBT ourselves as providers. So we're going to go into more detail with the different modes. So Jane is now in a skills training group, and there are 4 modules within DBT that really try to hold that dialectical stance of balancing acceptance and change. So the acceptance-based modules are going to be mindfulness, which so many individuals that really, really need DBT are the ones that struggle with that pervasive emotion dysregulation. It feels so intolerable, and so much time and effort is spent not being connected to how you feel in the present moment because it feels just and you don't know what to do with it. So a big chunk of this is getting connected with your personal, emotional experience and being an acceptance of that. Paying attention to the present moment on purpose. And it's really hard. And it's a muscle we can strengthen. Another acceptance-based module is distress tolerance. So this is really important because there is going to be painful moments in our day-to-day lives. And what we want to really get skilled at is being able to navigate those painful experiences and know that some of them we can't change. Some of them we can't change right now. So we want to go toward distress tolerance. When there's a crisis that we can't change right now, it's not something that we can solve, and it's painful. It's really tough. So distress tolerance helps us to both accept that that exists, that there's something that we wish would be different, we would like to be different, and to get through that moment without things getting worse. That's really the main goal, is that we might not always feel better when we use these skills. That's why DBT can be really, really difficult sometimes. What the goal is for it to not get worse. Often a nice little byproduct of using skills is that things do feel better. We do get some relief. And then the other side of that, the other two modules within DBT are change-based. So that's emotion regulation. This is where you really, there are definitely mindfulness components based in each of the modules. That's the foundation of DBT. But emotion regulation is really important. This is where the clients will learn to change unwanted emotions, as well as prevent unwanted emotions from happening in the first place, which means addressing our emotional vulnerabilities, taking care of our bodies to take care of our minds. So practicing good sleep hygiene. I know for me, if I don't get enough sleep, I'm walking around with a really big vulnerability than if I was able to get a good night's sleep. Also, interpersonal effectiveness is another change-based module. And this is addressing interpersonal dysregulation, which Molly talked about earlier. This is an area where, if you're really struggling with figuring out how to manage your emotions, or you feel really invalidated by the environment, then you may not experience the most effective relationships. There's that fear of abandonment is present as well as unstable interpersonal relationships. So interpersonal effectiveness is extremely important. This is where clients are going to learn how to effectively ask for what they need, refuse requests, be able to have conversations that they can stay in. Sometimes with the emotion dysregulation, we lose the individuals who struggle with that, because what we know is that when our distress level goes up, anybody, not even someone who struggles with pervasive emotion dysregulation, when our level of dysregulation goes up, our ability to process new information, our ability to stay in an effective conversation kind of goes out the window. And that's true for everybody. It's so much harder to do that when we're way up here. So interpersonal effectiveness, all these modules together are going to allow us to be able to stay in those conversations, especially the difficult ones, and get through effectively. So Jane is learning all of these things. Okay. So another thing that Jane may do, hopefully, is she'll engage in coaching. And here on site in residential, she might do that in person with staff. It's really structured with coaching. This is when you're having a hard time, you're feeling overwhelmed, you're in a crisis, and you need more support. So things, again, the goal is for things to not get worse. So in residential, we do this on site in person often. There are community counselors around here that will work with clients as well. They might step out of group if something is difficult for them to, if triggering, difficult for them to hear, they might step out of group and go get coaching. Another form of this, which I was speaking to earlier with comprehensive DBT, is that if it's after hours, like right now, Molly and I could possibly, hopefully not, be missing calls from our clients. And this is where they may call after hours to help with that skills generalization, to help with getting support. Sometimes it's just cheerleading. So Molly and I want to show you a little bit about what that might look like.
I'll be Jane.
We've got our props here. Oh good, I don't have any missed calls.
Nope. Me neither, good.
All right, so one way that we might experience coaching is with the good. So to report a success. So we're going to show you what that might look like.
All right. Ring, ring.
Hello.
Kate! Kate, it's Jane.
Hi Jane, what's going on?
Just wanted to call you and tell you how skillful I've been.
Oh, what happened? What'd you do?
So, okay, so you know how I was talking to you last time in session about my cousin, and he has just been such a jerk recently, and he's just been getting on my nerves. I want to let you know that I had urges to lash out at him and to yell. I mean, he said something really, really offensive, and I don't even want to bring it up right now because I'm just going to start getting angry. But, he said something, pissed me off, and I wanted to yell at him, and you know what I did?
What'd you do?
I stopped what I was doing. I noticed how I was feeling in my body. I took a deep breath, and I walked away, and I called you. I'm still angry, but I called you. I didn't lash out. But I just wanted to let you know.
Amazing. I am so, so glad that you called me.
Do I get a gold star?
Yes, you do. Wait, what'd you just say?
Do I get a gold
Oh, I
star?
thought you said something else after. Yes, you do.
Good. That's all I wanted. Thanks for the validation.
Yeah, thank you for calling and letting me know. Great job.
Bye.
All right, bye. So that's what it might look like if somebody was calling to report a success. So we want to join with the client in those successes because part of what phone coaching is at this level, when they're at the point where they can use phone coaching, is being able to cheerlead them and say, we're not so much guiding at that point. We're saying, all right, what'd you try? Let's troubleshoot, like walk me through what you tried. And what are you gonna do now? And you cheerlead, you be in their corner, be their supporter.
And so many times I just want to add too that these behaviors that we're trying to get them to stop have been reinforced by their environment, one reason or the other. If they're yelling and yelling and yelling and their parent gives in and just gives them what they're asking for eventually, they're learning that they're going to have to do that every time. So they've gotten reinforcement from their environment to do these, we call them target behaviors, the behaviors that they're trying to change. And by reinforcing their effective skill use, it's helpful in this behavior change, and it's shifting their ineffective behavior towards effective behavior. And if we have that reinforcement built in, it's really helpful in maintaining that progress.
Yeah, so we'll talk about it in a minute, but I might ask Jane to do a behavioral chain on that so we can figure out, how can we do that again? All right, and so this middle column is actually what we typically see when we have phone coaching, and that's the bad, which is when a client's really struggling and they're calling to get more support and troubleshoot something. Again, this is hopefully before engaging in the behavior. Now, if this is DBT at the outpatient level, if a client engages in a target behavior like self-harm and then calls for coaching, the therapist has a 24-hour rule where they're not going to reinforce by talking to them because they already got their relief from engaging in the behavior. So we want to reinforce them calling before engaging in the behavior to help them not do that. So with us at the residential level, we do take calls no matter what, or if they've already engaged in the behavior, and then we work on it in session because we do see our clients 3 times a week throughout the week to work on doing differently next time. So we're going to show you an example of when Jane's going to call struggling with urges toward her target behavior.
Okay. Ring, ring.
Hi Jane, what's going on?
Kate, I'm so pissed off. What's
going on?
I can't even talk about it. I mean, I just needed to call you, but my cousin is an idiot. He's such an idiot, and he doesn't care about me at all. And I just don't know what to do.
Can you walk me through, let's unpack that with the judgments, get a non-judgmental stance in there.
I know you said not to use judgments. Idiot just means that I feel like he's an idiot right now. I feel like he's being an idiot.
Okay, and I imagine he did something that was pretty upsetting.
Well, I was on the way to DBT group and I asked to borrow his car and he said no. And he knows that I have skills group, I have to get there, and he's being so annoying. Like, he needs to be able to let me use the car, and he's pissing me off. And I want to yell at him right now. And I know you said to not yell at him and to call you instead, so I'm calling you instead.
Well, I'm really, really glad that you're able to find the space to slow down and give me a call. That's huge.
Thank you.
So let's talk about what you want to try to do so you don't do that.
Okay. I don't know, I'm just so mad at him, I can't even think straight right now. I did try deep breathing, I did walk away, that's one thing. I walked away and I called you and I started breathing really, really deeply, longer exhale you told me about than an inhale, and that's helpful, but I'm still so mad and I feel like if I walk down there I'm going to yell at him.
Okay, well, you are off to a great start with the skills that you've used. So let's think about what you've done before, because I know anger gets a lot of energy going and you want to get that out. What have you done before that's helped to get that energy out?
Yes, intense exercise. Okay, I can probably do that. For like 10 minutes. I can do some jumping jacks.
Okay.
I don't know, maybe burpees. I need something more intense. I'll
Yeah.
do burpees. I hate burpees, but I'll do them for you.
Oh, okay. Well, I appreciate that, and I think that sounds like a great plan. And
Okay.
what are you going to do after those burpees?
Yell at my cousin. No, I won't do that. I just got an essential oil diffuser and I'm really excited about it.
Okay.
And maybe I'll use self-soothe and I'll smell the essential oils for a while until my suds decrease a little bit. I feel a little less upset. And then I can try to go to group somehow. I can't even think about that yet.
Okay, yeah, let's not go there, because we're not there yet. So this sounds like a great plan. Let's try some burpees and then do some self-soothe and further grounding with the essential oils.
Okay,
And
yeah.
you can call me back after and hopefully report a success.
Okay, I'll let you know how it goes.
All right.
Thanks, Kate, you're the best.
Okay, so that was an example of the type of call that we typically get. And then there's also the ugly, which this one, it's really important because a big part of the work is the collaboration with the therapist, and that's such a very important relationship to have. It's one of the most vulnerable relationships we can have. So if you have an experience, if Jane feels in any way that she's been invalidated, that she feels alienated, or has some kind of conflict or distance with me, then it's going to make the work really hard, really impossible. And so she's already, going upstream against her own pervasive emotion dysregulation and other areas of dysregulation. So we want to make sure that we're addressing this as well. So we're going to show you a little example of what this might look like.
Okay.
Hi Jane, what's going on?
Hi, Kate. I'm just calling you because, last time in session, I was walking out and, I really wanted to talk to you about my cousin, about how he's been getting on my nerves, and I just kind of feel like you brushed me off, and we couldn't talk about it, and I feel like you just don't care about me.
Okay, well, I'm really, really glad, Jane, that you called, because that's, the last thing that I want to do is make you feel unimportant or brushed off. I know how important that is to you, that
Yeah.
relationship with your cousin.
Yeah.
So I appreciate that you called, and I'm sorry that happened that way. Do you remember what I said when you brought it up?
You said that you wanted to talk to me about it next time.
Mm-hmm. Yeah.
I still felt like you didn't care.
Well, the reason I wanted to talk about it next time is because I know how important this is in your work, and I want to make sure that I give the space and time for us to really talk about it.
That's
and get
true.
in there and look at that and work on it.
That's true. That's helpful. That's validating. Do you think you can say that maybe next time?
Yeah, like remind you that we want to have the space for that. I think that's a great idea. I can definitely do that, work on that.
Okay. I feel better.
And thank you for calling. I'm glad that we talked about it.
You're welcome.
Great.
See you Thursday.
Sounds good.
Bye.
All right, so that's an example of how you might get a coaching call to address an issue within the relationship with the therapist. All right. So then another mode of therapy that Jane's going to experience is the individual session with me. So Jane's going to come in and see me on Thursday, and we're going to talk about one of the coaching calls that we had. We're going to first start out with looking at what's called a diary card. So I like to call this the ticket to session. That this is how my clients are able to come in and start session, is that they have their diary card completed for up until the previous day. So a diary card is what really helps make this an evidence-based approach, is that on that card, the client, and this is also part of self-management, is keeping track of behaviors and urges that we've agreed upon are things we're working on while they're here with us. So on the diary card you might see suicidal ideation, urges 0 to 5, and a client will document the highest level they felt that urge for that day. So even if they're experiencing ideation at a 1 out of 5 all day, and for 1 minute it pops up to a 2 or a 3, we want to see that 2 or 3 on the card, and we want to talk about that. What happened in that slice of time that led to an increase in suicidality? So the diary card is how we track how we're doing and what we need to focus on, and it's going to be really what guides the session. So if a client is endorsing suicidality, we're not going to spend time talking about, like if Jane says, my suicidality went up to a 2 out of 5 yesterday, and typically it's at a 0 or 1. We're going to talk about that before we talk about her urges to lash out. So we go by a hierarchy. An intervention that we may use, and we'll go through an example of this in a moment, is a behavioral chain analysis. This is the bread and butter intervention of DBT. It's great. It's an insight building intervention and exercise where you really get in there and you see what happened for a person. If we were targeting, like if Jane lashed out at her cousin, we would really look at what happened moment to moment that led to that behavior. And then we look at the other part of that, which is a solution analysis, where we see and look at if there was anything we could have done different, any step of the way, might this have gone in a different direction? And we start to build up and apply skills to the different links on the chain. And again, we'll go into that more in detail in a moment. Let's see. Skills training. This is, again, happens in individual. It also happens in the groups. So an individual session, we might talk about it in more detail and as applicable for a client's specific target behavior. If we're in session and let's say we're working on a behavioral chain analysis, which can be pretty dysregulating because again, we're asking somebody to think about in great detail something that probably is pretty dysregulating. So if I was chaining with Jane an increase in suicidality, it's probably going to be pretty uncomfortable or dysregulating to think in detail about the things that brought up suicidality. She might find herself in a very similar place, like noticing her suicidality is going up. So as we check in during session, if she's becoming dysregulated, we may stop and use skills in session together. If she doesn't know the skills well, I'll model them for her and guide her through it. If she does know the skills, we'll do them together, or she'll use skills independently, and then we'll try to come back to the intervention.
Also, I want to add with that is if you're going through a chain analysis and you're going into the solution aspect where you're trying to think of ways to do differently next time and what skills can you use, and the client hasn't gotten to that skill yet in their skills training group because it's a long module, it takes a long time to go through all the skills. If they're not going to get to that skill yet, you could take the time and teach them in session because in that case they might need that skill specifically for the behaviors that they're struggling with now, and you might decide to pause the session and teach them that skill because it's what it could be helpful for what they're struggling with in the moment.
And then practice. We'll set practice assignments for clients to go out and practice these, or we'll practice together in session just to get that familiarity. And it's a lower level intensity. Like my client or Jane asking me for something, like if she was going to ask her cousin to borrow the car on her skills training group days, it's probably going to be easier to role play and ask that of me and get familiar with the skills rather than trying this out the first time with her cousin. What is happening? Okay.
Who's being like that with me too? All right, so let's talk a little bit more about the chain analysis, because in most DBT sessions that are adherent to DBT, you'll do a chain. You'll conduct a chain analysis. The point of a chain analysis is to build insight, like Kate said, around what led up to this behavior that we're trying to change and what happened afterwards. So what might have been reinforcing about the environment afterwards, what were the negative consequences of the behavior afterwards, and then to identify skills to implement in the future to do differently so you don't go down that same path over and over again. So the first thing, other than identifying what the behavior is, that you're gonna, we call it chaining, it's a verb for us now. Like Googling, we're gonna chain that tomorrow. So the first thing you wanna do is identify the prompting event. The prompting event is what some people call the trigger or the cue. Whatever in the environment really got the ball rolling on this sequence of events that led to this behavior. So for example, the lashing out would be the target behavior. The prompting event, we'll get into this when we do the example, might be Jane's cousin telling her, no, you can't borrow the car. And then everything in between the prompting event and the problem behavior, we look at in excruciating detail to figure out what went on for that person, what went on in the environment. And before the prompting event, we look at the vulnerabilities. So vulnerabilities in this sense mean anything that you might be feeling or that you were going through recently or historically that made you more likely to act in emotion mind, meaning act on your urges, as opposed to staying effective. So for example, maybe it can be not sleeping well the night before, not having lunch and getting hangry. Who gets irritable when they're really hungry? That's a big vulnerability. It's long races. Yeah, so it can be a lot of those kind of physical things. It can also be a history of trauma and something kind of happens to elicit those responses within you. It can be maybe Jane was feeling more irritated with her cousin more recently, so she was just kind of more on edge around that person. It can be a lot of different things. And vulnerabilities are really great to identify because if you can take care of those just as a baseline, you're a lot less likely to act on your urges that are ineffective. The next thing you do, between the sequence of events, so the prompting event, all the way through to the problem behavior, you identify the links in the chain. So these are the emotions that you feel, the thoughts that you have, the urges to engage in behaviors or the actions that you do engage in, events in the environment, and also body sensations. I don't think that one's on there, but the body sensations that you feel. So you felt tense, and then your heart was racing, and then you got shaky, all these things. So you'd want to identify as many as you can sequentially between the prompting event and the problem behavior. Because the more links that you have, the more opportunity you have to implement a different skill. So if you had a certain thought like, oh, they don't care about me, you can use a specific skill to target that thought. And so each of the links you can use as an opportunity to break the chain, right, and do something differently. So the more links you have, the better, because there's just more data and more opportunity to do something differently. The problem behavior, kind of like we already said, is stating what you've done, not just generally, but it's very detailed. It's kind of like the who, what, when, where, why of the behavior. So I lashed out at my cousin on Thursday night in the kitchen with a candlestick and Colonel Mustard. Like, you want to be very specific. about that. Because when you look back and you've done multiple chains, you can find patterns in this. Oh, I always self-harm when I'm alone in my room at night. Oh, I'm always ruminating at like 7 p.m. when so-and-so leaves. You can look at what the patterns are and then really get moving around the change. And then the consequences, kind of like I've said already, are potential reinforcers, so things in the environment or within yourself that reinforce the behavior. So maybe you felt immense relief after you yelled at this person. That's a reinforcer. That's a positive consequence. Can also be negative consequences. So feeling guilt and shame are really common negative consequences of target behaviors. So after you engage in something, you regret it, or you feel bad about maybe the impact on someone's relationship that you care about. With self-harm, a lot of the time it's scars. Like you feel the negative consequence is that you don't want to have these scars of self-harm. It can be a lot of different things. So Kate and I are going to show you an example of how to conduct a chain in session with Jane. So now it's Thursday, we're in session, and I've come into session, I'm Jane now. And I've told her that I've lashed out at my cousin, yelled at him, argued, cursed, all that fun stuff. Okay.
Well, Jane, I know that you called me for coaching to talk about trying to use skills around that urge, and it sounds like
Yeah, it didn't work.
that there was a little bit of difficulty there. And again, I know this is really important to you, so what I'd like to do is look at this in more detail so we can figure out you were on this path and somehow got off that path. So we want to see where we went off path and how, if this comes up again in the future,
Really let him have it this time.
we might try to do something different.
Okay.
So we want to start out with looking at those vulnerabilities. What was going on that was kind of hanging over you that made it more difficult to follow through with the skills?
Well, okay, so this happened on Tuesday, and I remember Monday night I stayed up until like 2 a.m. watching Netflix, and I just couldn't stop. I was binging on the shows. So I didn't sleep well
Okay.
at all.
So not much sleep.
Um,
Anything else?
yeah, I mean, I missed skills group last week, so when he said that I can't use the car, I was even more worried that I'd get kicked out.
Yeah.
So that's a vulnerability, right? That I didn't go and that I was just already on edge about making it there.
Definitely.
And I'm sick. I mean, I've been sick for a while, so just physically I've been feeling horrible. And he's been getting on my nerves recently. So,
Yeah, so it's a lot of vulnerabilities I can see now. Knowing all of that was going on for you, I can see that was probably difficult to experience him saying no. Okay, so what do you think really set it all off? What put it into motion?
I mean, he told me, so I asked him, I have to say not as skillfully as I would have hoped to borrow the car. It was kind of last minute. I probably could have validated him a little bit more before I asked. But what he responded, he was just like, no, not at all, you can't borrow the car.
Okay, so let's look at that one slice of time.
Okay.
In that moment when he said no,
Mhm.
what was your first thought? What were you thinking?
He's an asshole.
Okay.
He's a jerk. He doesn't care. Yeah.
So a lot of those thoughts.
Judgment.
Uh-huh.
Yeah.
And then what emotions were coming up from that?
Anger. Like 9 out of 10 anger.
Okay, so that's really high, like right off the bat, really
Yeah.
intense anger.
Yeah.
Was there any other emotion?
I mean, I was afraid, I think maybe fear. I was afraid that I was going to get kicked out of my DBT group
Yeah.
because I really, really wanted to make it there.
Okay.
And so I was afraid too.
And what about body sensations?
Tense. I was hot, I was flushed. My fists, my hands were in fists. My jaw was clenched. I started shaking. Yeah, lots.
I remember on a past chain, we noticed that those body sensations are red flags.
Yeah.
Okay, all right. Okay, and then what happened next?
Well, and then I said, you're being really selfish. And then he said, I don't care.
Okay, so now we're gonna look at that slice of time. When that happened, what thought did you have?
He's an asshole again. And then I thought I'm never gonna get to group and I can't handle this.
Okay.
Yeah.
All right, so now that kind of thought sounds like it's getting even bigger.
Right, my suds went up.
Yeah,
They were at like a 10 out of 10. 9 out of 10. I
okay.
was pretty upset.
And what emotions were coming up there?
Rage. And maybe some desperation around I need to get to group, how am I gonna do this?
Yeah.
Yeah.
And any different body sensations?
Maybe at that point I was more numb, I don't remember. I think I became more checked out.
Okay.
Yeah.
And then what happened next?
And then I screamed at him.
Okay.
I said a lot of things. Yeah. Yeah, I kept yelling and I was cursing. I don't even really remember what I said. I was like blacked out. But I yelled at him for a while. Yeah.
Okay,
I
so
felt really bad.
that's the behavior that we're looking at, right?
Yeah.
So what was the consequence of that? What was the result?
Well, afterwards I felt a little bit better and he actually let me borrow the car. So I got to group. It worked, right?
So that was a positive consequence.
Yeah.
That the need was met,
Yeah.
and we know that there's also other consequences, right?
Yeah, I felt really bad. I mean, he's not very happy with me right now. And I felt shame. I felt ashamed and regret. Because I don't even know what I said.
Yeah.
Yeah.
And you know that relationship's really important to you.
Yeah.
Okay.
Yeah, he means a lot.
Well, now, why don't we take a step back from this, because this is a lot of data, you did a great job walking through it, and let's see if we can try to identify ways that if this comes up again, we might be able to try something different.
Okay. Well, thinking back to those vulnerabilities, I probably could have gone to bed earlier instead of watching Netflix for that long. And then I wouldn't have been as tired. And then, you know, I probably would have been able to think things through more and maybe walk away earlier instead of just letting him have it. That was bad.
Okay.
Yeah.
Yeah, the vulnerabilities, if we can nip those in the bud, we might be able to handle him saying no in a different way, okay?
I also thought, because I brought this up with you too, that I didn't really ask well. I didn't ask him very nicely. I probably could have validated him a little bit before I just said, hey, can I have the car?
Yeah.
You know, I probably could have said, I know this is really last minute and you're probably really busy and this is really important for me to get to group.
Yeah.
Like, could have used more validation.
Okay,
Maybe he would have been more receptive.
great.
Yeah.
Any other skills you think might have been helpful? Like what about when you noticed how high that anger was?
Yeah, I mean, our skills plan just went out the window. I couldn't even think of the intense exercise, the deep breathing, dunking my head in the ice like you told me about, holding the frozen fruit, which sounded so weird to me at first. I mean, it works, I just couldn't think of it. Could have done that, probably grounding too.
Yeah.
Just being more in touch with my body and where I am in the moment and walking away.
Well, why don't we make a plan and do maybe a cope ahead for the next time you need to ask him for this and incorporate those skills into it.
Okay.
So we can try, we know that this might be difficult to do and that there could be some vulnerabilities present and try to build up some skills around it.
Okay, that sounds good.
Good job.
Thanks. All right. So, that's an example of a chain that you would do in session. Normally, we'd either write it out on a board, on a whiteboard in our offices, or we have them actually at the same time write out on a piece of paper the chain so they can keep that and keep looking at it when they go back to new chains and engaging more behaviors. They have a record of all of the chains that they've done. And as you guys saw, we went through the solution analysis there. And typically what we do is write down a skills plan and maybe cope ahead of time for the next time I have, or Jane has an urge to lash out at her cousin. And, oh, wow. Did you even know that we were this fancy?
I think I made this years ago.
Oh,
I just forgot.
Cool. So the last thing we wanted to touch on with all of you before we end and go to questions we wanted to bring up some potential questions that you can ask when you're looking for a new DBT provider to help determine if they're doing adherent DBT as opposed to what a lot of people call DBT-informed therapy, which may be very effective. There just hasn't been a lot of research on what DBT-informed therapy means, and it can mean a lot of different things. Usually what it means is that someone knows about DBT but might not be fully trained in it and kind of like, or they might be and they just kind of implement pieces of it into their own practice. So when you see DBT informed, it does not mean adherent comprehensive DBT. Certain questions that you can ask will be helpful for that. So if you ask about phone coaching, that's a great sign that they do adherent DBT, because you're going to be able to generalize the skills to other situations other than just in group and in session. You can ask them if they have a skills training group and how often they meet. Regular outpatient DBT will have usually a once-a-week skills group led either by that therapist or by someone on the same team as them. And then, do you sit on a DBT consultation team? So these questions are essentially checking to see if they had all of the modes of comprehensive DBT treatment. And then, do you use a diary card in session? If they don't use a diary card, it could be hard to imagine how they're doing adherent DBT in session, because it's such a great tool to structure what you target in session and how you track how you're feeling, how you remember how you were feeling a few days ago. And it's a great way to have consistent data over time to measure change over time. So that's another thing to ask. And then if you're intensively trained or certified in DBT, that's another great question to check on. Intensive training is usually the gold standard for being able to do comprehensive DBT. If someone's certified in DBT, that is a great giveaway that they're able to do comprehensive DBT, because that's what that means, is that they've been certified through a board that confirms that they're able to do it to code, to adherent DBT. We're actually in the process right now of certification as a program, so we're working towards that, and it's a great thing to have as a provider. So now we are going to move to questions. If any of you have questions for Kate or I,